We do live in an age of medical miracles. We already heard this morning how we've got large-scale science projects bringing together new measurement technologies, large-scale analysis of data. We've never before been able to understand the cause of disease and come up with new ways of treating it than we have now. The fact that there's a major outbreak of Ebola now in Africa and we're already contemplating vaccines in such a short period of time is really an amazing compression of that discovery phase. Now, in contrast, our understanding of the health system that is meant to deliver these miracles is way behind. I can't even tell you what kind of a system it is mathematically. I don't know what the rules are that govern it, what the laws of physics are that might be describing how health services do what they do, and yet we're really depending on the system to somehow deliver all these new discoveries. So I guess the challenge for us is to understand how we take a service industry that has a 10% error rate, 2% serious errors in healthcare that is increasingly inefficient, and make it this machine that we would like it to be to look after us. As an analogy, think of medical science as a GPS. We're going to discover the route, I guess, from disease through to health. But that GPS doesn't tell you what form of transport to get. Should I get a bus or a car today? Doesn't tell you where there's going to be traffic congestion or where maybe you need to think of a new route because there's a roadblock. Those bits of information reside in navigating the health system. And that's really what I'm going to try and talk to you about today through a couple of case examples, just to get you to understand how challenging it is to understand how health services are delivered. So our vision really is that we would like to wrap around you a digital safety envelope as you progress through healthcare, that we're looking at all the data that we're gathering about you and letting you know when you're starting to move into a space that's unsafe. The other part that we would like to do is to monitor ourselves. We've already heard about the Internet of Things, to monitor how the health service system itself, that machine, is performing, whether it's actually doing the right thing by you or not. And hopefully those alerts won't always be that serious as in this example here. So let's start with case study one. You might expect, just because your doctor has ordered a test for you, that they would look at the test result. You've gone through the pain of having that blood test, of having the X-ray, the MRI, but you would be disappointed to know that in fact that's not always the case. So here are a couple of numbers from the US, which is always an outlier health system. So, so we do know from the studies in the US, between 20 to 60% of inpatient tests in hospital are not followed up. Already you're thinking, well, either that test was important and you really needed to know that result because that might affect my care, or you didn't really need to do that test and I've just paid for something in one way or another that I really shouldn't have. That was an unneeded service. And the next data point that simply shows that in nearly half of the cases of malpractice in the US associated with poor diagnosis, this failure to follow up test results was one of the causes. Interesting. So we looked at what is going on here and did what I would call a small data exercise, looking at about 700,000 patient results at one teaching hospital here in Sydney. And the good news, I guess, is that our failure to read those test results is much lower than those US numbers. About 3% of tests didn't get reviewed at discharge. What was not so good was about 40% of us as patients had at least one test that wasn't followed up, and about 20% of those tests were abnormal. So, a concern. Now, this is where the title of the talk comes in, because this is as far as standard health analytics took us. Lots of stats, but no explanation. What is going on here? Why is this happening? And I can tell you that my team spent many months looking at screens of different tests and associations, but there were no real patterns here with raw association. We had to go back and start to think about what was happening in the process, what were the laws of physics governing this process. And we came up with a very simple rule, which was to say, look, clearly the opportunity to look at a test must increase the longer it's sitting in the in-tray. Let's try and plot what happens to test follow-up based on how long it's in the system. And we get this really interesting graph. You can see for any tests that have been hanging around a long time, there's a good chance that they've been seen. nearly all the tests that don't get seen are in the first day. At discharge, 21% of tests are not followed up. In fact, nearly 40% of all those tests, so nearly 50% actually, were ordered on the day of discharge. Now, this is really important because at last I now have something that's actionable. I can now start to understand causality here. And clearly there's a disconnect between the process of ordering tests and the process of sending you home, discharge. People are ordering tests ignorant of the fact that you're going home, or they order tests importantly but forget about you because you've gone home and you're now the GP's problem. So we can now start to think about system fixes here. So this is all about going from big data analysis, which tells us there's a problem, to thinking about the problem and coming back with humans to understand what's really going on. Okay, the next case study might be more troubling. Do you realize that your chance of death is much higher if you're admitted to hospital on the weekend? Right, it is. So this is not because on the weekend we've got lots of concussions coming from football turning up or lots of car accidents. What it means is if you were to be treated for a heart attack or an accident on Monday to Friday, you do better than if you're treated for exactly the same condition on the weekend. And that's a global thing. That's not just something here in Australia. And there are really just two possible causes. One is simply that the people who turn up on the weekend, for some reason, are much crooker, as we say in Australia. They're sicker people, and that's why they're dying in greater numbers. The second unpalatable explanation is that we're not looking after them so well on the weekend. Maybe we've got lower staff numbers, maybe services aren't available. And so when people look at this around the world, we really haven't been able to untangle what's going on here. What is the causal process that's making all this happen? And again, that was our motivation when we did another study. I might call it a middle data study, not big data. We looked at about 3.3 million admissions now to hospitals in this state of New South Wales. And we did find the weekend effect. You can see there it exists. It's about, 0.4% chance higher risk of death on the weekend. But that translates into several thousand people in New South Wales dying. So although it's a small number, it's quite a big number if it's you. And the standard analytics took us a little bit further. It shows that most of the problem sits only in about 16 specific classes of disease, 16 groups, but they account for about 40% of the deaths. But again, this is where the standard health analytics left us stumped, because when you looked at the list of diseases, it was such a mixed bag. There were heart attacks, there were lots of different cancers, there were strokes, pulmonary embolism. There was no pattern here that really made sense. So we again had to go back and say, well, what do we think is going on? What are the laws that might be governing this behaviour? How do we untangle causation, given that it could be sicker patients or poorer care going on? And we came up with, again, a very simple model after a lot of thinking. And I don't want to scare you, but basically, so the simple model says, look, if indeed it is poor care that is the cause of weekend death, then we should see a spike in deaths that disappears on Monday when you get re-exposed to the A team. If it is the fact that people turning up on the weekend are somehow sicker patients who have more risk of death, then that excess death rate should be steady. Even once they come back to Mondays, they should be sicker at all times. And so that really gave us four possible things that we might expect when we looked at the data. Firstly, for those diseases where there's no weekend effect, you shouldn't see any difference. So if there's going to be this poor care effect, you'll see the spike. If there's this other pattern of really sick people, you'll see this persistent elevation. And it might be the case that in some disease groups, you see both. So what did we see when we took this more basic level thinking to the data? It actually all fell out really simply and clearly. We now know pretty much what we think is going on. So the top two graphs here are really where care is the problem. And there was only one disease group in which care was really clearly driving poor outcomes, and that's heart attacks and cardiac arrhythmias. You can see that the risk of death plummets after a day. The moment you're back in on Monday, you're back to normal, your risks are normalised. What's going on here? Clearly, this has got something to do with poor access to imaging, maybe not getting the stents quickly enough, having to call in radiology to do something which might take 3 hours. We know that the time window you have available for a good outcome with these diseases really is critical. So this is really a care effect. We have to do better here. And we saw much the same pattern with people coming with other acute cardiac conditions. The bottom two are where all the cancers sit. These have this steady risk pattern over time. And clearly when you talk to the cancer docs, they say, well, look, that makes perfect sense to us, because what's happening is we have people in the community being looked after by the GP who are doing poorly. And the GP is hanging on. It's Friday afternoon, patients deteriorating, the GP can't handle them, so off they go to hospital. And so this is a sicker group of people coming in too late. They should be coming in Monday, Tuesday, Wednesday to be looked after and get the care they need. So it's really interesting, isn't it, in a sense that you can have lots and lots of numbers, but they don't tell you very much at all until you start to step back with an understanding of what's really going on. This is where people come in, and you start to draw a story out and use the analytics to help you understand what the true laws of physics might be here. So let's just really finish by saying the first part of the big data story really is that information that's collected and acted upon has no value. And all of the data I've used for these analyses here are routine data sets that exist. They've got nothing to do really with the medical record or your health. They've got to do with the process of delivery. They're just instrumenting the machine. But just looking at the data doesn't get you anywhere. You've got to come up with an actionable story. Information only becomes valuable when we understand what's going on and is actionable. And to do that, we don't just need big data and computers and smart analytics. We need people who understand how the system works. Thank you.